Good evening. Good evening, my dear friends. Am I audible? Good, thank you. I could see regular routine, familiar faces. Myself, Dr. Subodh, one of the online mentors. Probably today, online, I'm in charge of today evening webinar. Dr. Chaitali will be coordinating this event. Ma'am will be soon entering into the chat box right now and into this Zoom video also. So today evening, today's topic is digital planning for basal implantology. So hope we'll wait for another 1 more minute. We have around 30 participants right now. And Dr. Rohit, also India Bashir, Dr. Monuddin, yeah, Dr. Sumit sir. Dr. Mayuri ma'am, good evening. One of our mentor in Bhopal. From Impact Airline Series and from Krishna Enterprises. Excuse me. From the Impact Airline Series and from Krishna Enterprises. I would like to invite each and every member today for today's evening webinar regarding digital planning for basal implantology. So we are having some of the upcoming events also. And after today's webinar, we have an pterygoid and a zygomatic course in Mumbai. We have 3-day corticobasal implantology coming up in Bhopal by Dr. Mayuri ma'am from 9, 10 and 11th of this May. Then we have Dr. Robinson's zygomatic and pterygoid workshop in Mumbai on 25th and 26th of May, the same month, last week. Then we have a 3-day basal implantology course by Dr. Rohan sir, comprehensive implantology workshop from 13, 14 and 15th of June in Mumbai. Then in 3-day implantology, basic implantology workshop in South India near Coimbatore, Palakkad, 27, 28 and 29th of June. Then we have 3-day basic implantology workshop by Dr. Mayuri madam. Again is on the same day, 27, 28 and 29th of June in Bhopal. So these are the 4 upcoming courses. We have one advanced course in zygomatic and pterygoid workshop also, and also the 3 basic courses conducted in Bhopal, in Mumbai, and also in Palakkad near Coimbatore. We are also having a boot camp, upcoming boot camp from 9th and 10th and 11th of this month, May, in Bhopal. So the basic criteria or why we should have a digital planning in a corticobasal implantology, or whenever we do a full mouth case or a segment or a single case also. The golden standard rule for our basal implantology is our OPG. I just have an introduction and then we'll go in detail. It will be an interactive session also, so that you can have you can post your doubts and all those things in your chat box, so that I can and Dr. Mayuri ma'am also will be there. So both of us can have an interactive session later on after the session. So why we require a digital planning of an corticobasal implantology doing a full mouth case or doing a segment or while restoring a single tooth is that what we can go ahead is golden standard for an implantology or when we go for the full mouth case is OPG. So when we see the OPG, we can see it as in the maxilla we shifted into zone A between the two distal wall of the sinus. Then we have zone B, that is the area which is under the sinus. And then we have zone C, which is in the posterior of the sinus area, that is your tuberopterygoid region. In zone D, in the mandible, it is between the two mental foramen region, and zone E is your posterior mandibular foramen region. Okay. So these are the 5 zones which we normally talk about and which we require all your corticals to be involved in your implant so that you can give a nice processes which can dissipate your forces. So before going into the subject very detailed, why we should require OPG, why we should require a CBCT, and how to go about, and all those things will be discussed in detail during this session. I think Dr. Chaitali ma'am is also there. Ma'am, can we move ahead? Okay. So when we have a digital planning, we'll be into the session right now. When we have our case with the OPG and also with the CBCT, the advantage or why we should have this type of required digital planning not only with the OPG but also with the CBCT also is that we can get to know about the anatomical landmarks and the vital structures which are there in and around the perioral tissues and in the maxilla and in the mandible in a better way. Secondly, the strategic positions of corticobasal implant. What are the strategic positions? In maxilla, we should have a pterygoid as the distal stop. Then you should have a canine as the mesial stop. In mandible, you should have a canine as the mesial stop. And distally, you should either enter a lingual cortical engagement or a knuckle cortical engagement. So all these things are the strategic positions. You should have all the supporting implants between these strategic positions and all the stabilizing implants outside the strategic positions. So in order to get a confined strategic area, you should be well aware of where are the strategic positions and how the implants has to be planned out. Secondly, you should be able to know what will be the sizes of the implant, how deep is the corticals in the area, whether that particular cortical is a, I would say it is a dependable cortical or a non-dependable cortical, whether it is a good cortical or an unstable cortical which is infected with a cyst or a granuloma or something else. So these things are very much important to know how we should be planning about the implants and implant sizes. Since occlusion is the key factor of corticobasal implants, you should be well aware of that. All your occlusal points should be well within the strategic limits of the implants, that is between the canine pillars and between the pterygoid areas. Anything out of that particular occlusal table, you are taking a lateral interferences outside the polygon concept. The polygon concept is a detailed area where all your occlusal table and the occlusal forces should be confined inside the supporting polygon. Now, according to Dr. Rohan sir, the SPIL protocol, that is simplified protocol for immediate loading, requires 3 mandatory concepts. One is all the implantology works on force distribution. So force should be effectively distributed to the deeper corticals. So force distribution is mandatory. That is, the spread of the implant should be mandatory. Second, you should engage the deeper corticals for better dissipation of the forces. Third one, you should judiciously use the available of bones, available cortical bone for better distribution, for better engagement, and literally to give a good occlusion within the supporting polygon. So the digital planning becomes very much important again for the SPIL protocol also. Now what happens? You have already posted and case. You have an OPG ready, you have a patient ready, everything armamentarium is ready, but you never know what are the sizes you should be requiring. Of course, we'll have a 50 implants in stock or something like that in and around. And normal sizes are also available, regular sizes are also available. But in some cases, often a slight angulation changes or slight variation, small angulations and all can you may require during the operative phase may require and higher sizes. Yeah. Okay. Am I not can you see me, sir? Or
Sir, we can see you. Are you presenting something?
no, sir, I'm not presenting. Can you see my video, sir?
Yeah.
Yeah. Am I visible?
Yes.
Nitin doctor, am I visible?
Yes, sir.
Yes.
Visible, sir.
Yeah.
Video is fine.
Video is fine, no? Yeah, fine. We'll start the screen sharing in another 5 minutes. Dr. Nitin, you will be sharing the screens.
Okay, I'll share. So you let me know.
Yeah, fine. So often we'll be running short of the sizes of the implant or on the dia of the implant, that is maybe 3.5, maybe 4.5 or a 5.5. So all these things will have some impact on how we are going to do the cases. So for effective usage of our time, for the effort what we put, for the time management, you start the case, you finish off in first in one hour, in another 30 minutes to 45 minutes, lower arch in another 30 to 45 minutes, so that you don't leather or you don't haggle your patient's time. Your chairside time will be reduced actually when everything is ready. And you don't unnecessarily incur the cost also. So effective usage of the time also requires a proper digital plan. So this evening, we will be doing a 2 maxillar and 1 mandibular digital planning, and we'll see how the things are coming out and how effectively we have reproduced it. Post of OPG also can be seen. And if or to another extent, if you really want to go for a guided surgery, how well you can go ahead with the guided surgery also, we can go ahead. So now I start my screen sharing. So Nitin, you can have a screen sharing done.
Yes, sir. I'm sharing.
Yeah, thank you.
Hello.
Yes.
Yeah. So I hope everybody can see my screen. Hello.
Yes. Yeah.
So the screen is visible?
Screen is visible. Screen is visible.
Okay. Hello, everyone. Good evening. My name is Dr. Nitin. So I've been working with Dr. Subodh in helping him with digital planning, guides, everything since quite some time now. I think since 2019. So it's been an honor to be assisting sir with all this because I also got to learn a lot. As someone from an oral medicine radiology background, I was not much into about the theoretical basic implantology and all those things. It's been a journey, and I've been with help of Subodh sir. I've been in this journey for some time, and my knowledge about how to plan, where to plan, and all these things it's been very nice. Okay, so that's about me. Now today, I don't want to waste time, so let's start with this case. This is a completely edentulous upper and lower case. Some recent extractions. So, sir, we'll start with the maxillary plan.
Yes, sir. We will be doing the upper arch, sir.
Yeah.
The patient name Sringa, we will be doing the upper arch. Now, we will be dealing with, now we are dividing it into three zones. Zone A, that is the premaxillary segment, that is the area between the sinus region, nasal wall of the sinus. That is a zone A.
Yes.
Now we have a zone B, which is the sinus area.
Sinus area and the pterygoid.
Most area posterior to the sinus is the tuberopterygoid area, which is the zone C.
So shall I start planning from the pterygoid?
Yes, sir. We will start doing it from the pterygoid areas. So zone C will be initially we'll be starting with zone C. So as our mentor says that when we start our treatment, whenever we do a case, we always start with our pterygoids. The reason is for better visibility, better mouth opening, and they will be also fresh with our knowledge. And of course, pterygoid anatomy is a blind procedure, but again, with a sound knowledge of the anatomy and also with CBCT and OPG, we will very well assure that we are in the tuberopterygoid region. So just brush up with the anatomy structures. On the left lower area, you can see the skeletal form of the patient. Now here you can see when you run your forefinger from the premolar area, palatal wall towards posterior, you can see a very sharp prominence that is called as hamular process. So hamular process is nothing but it is the extension of a medial pterygoid plate, which is a part of sphenoid bone. You can just see the cursor actually. You can see the hamular process. Okay. So in order to palpate your hamular process, what you need to do is you have to run your forefinger from the palatal aspect of the first premolar and run posteriorly into the posterior palatal seal area, PPS area. And soon after that, you will see a very sharp prominent area that is called as hamular process. Now, second anatomical landmark which is very important is your hamular notch. Hamular notch, in order to see or in order to appreciate the hamular notch, we should see the sagittal view. See, the sagittal view will show you where your maxillary tuberosity ends. Maxillary tuberosity ends. That is the distal mole part of the maxilla. When the maxillary tuberosity ends, and then you have a small depression, or simply for a simple term, where your denture ends. That is the covering part of your tuberosity. That is your hamular process. Fine. Very two important landmarks. One is the hamular process. That is the part of medial pterygoid plate. It is the sharp point which is extending from the extension of the medial pterygoid plate. Now, next one is your hamular notch. It is the distalmost part of your tuberosity. Is the notch. Okay. Now, you can appreciate in the axial section is that your medial pterygoid plate and the lateral pterygoid plates form a fusion. That fusion is called as tuberopterygoid fusion with the pterygoid plates. Tuberopterygoid fusion. It is a very thick, dependable cortical area. So, in order to access that area, what you need to do is you should do a reverse engineering. So, how do we do a reverse engineering? In the sagittal plane, you should draw an imaginary line from the hamular process through the connecting the hamular knot to the crest of the ridge. Okay. So, you do a connecting, you do an imaginary line from the hamular process through the hamular notch to the crest, crest of the alveolar ridge. So it will not be the same as that on the left as that on the right, because left side the tooth must have been lost very early, so there will be more of resorption. Maybe it will be more permissively. On the right side, the resorption pattern will be the tooth must have been lost very recently, so there will not be having much of resorption. So you need to go more medially. The other side, more or less, it is straight, or more or less it should be a mild medial. The angulation will be a bit palatal, only that much. Medial and palatal is always the same. Now the angulation or the direction of the drilling sequence and zone C, tuber area is posteriorly, superiorly, and medially. Posteriorly, that is distally, then you need to go superiorly, and then go medially. How do we go medially? That direction is determined by the imaginary line which we have drawn connecting the hamular process, hamular notch, to the crest of the ridge. Here, this is done. Can I have a thumbs up if it is done? If it's okay, can I have a thumbs up?
We will start placing and then there.
Yeah. Perfect. Thank you. Okay. Now, how do we scout that particular tuber pterygoid fusion area? Take a seed finder to the imaginary line. Just tap that particular area. Tap nicely. Initially, you will be in the tuberosity area. That is almost a D3, D4 area. You will get a muffled sound. As and when you go more deeper and deeper, posteriorly, superiorly, and distally, what you can see is you will have resonance, or the sound gets more and more sharp. That means that you are nearing a highly mineralized zone or a dependable cortical area. That is called as tuber area. Here, now we will just place an implant, or we will finalize the position or the path, place the implant and see what will be the length and what will be the of the implant. In both the time, we will have two choices, whether we need to go with a compressive one or an viscous one, smooth surface. Okay. Now we'll get the section done. Doctor, zone C.
So this is the right pterygoid.
Yes.
So you can see here I'm measuring the distance from the pterygoid plate. This small division is the pterygoid plate, this is the tuberosity, and to the crest, and beyond the crest to the shadow of the soft tissue. Okay, so that is approximately coming up to 21.9. So in BCS we have 23 implant. So you can do a virtual implant with that. So what I do is I make a custom implant of any of the available sizes. And we place it. The idea is to understand, like if we place it in that direction, 360 degree, how is the bone coverage around this implant? So we'll get a direct visualization of that both everywhere from the 3D view to the individual sections. You can see I'm trying to adjust it in all planes. This is the axial plane, this is the coronal plane, and this is the sagittal plane. So that is it's a three-dimensional plane. You're viewing that implant in all three dimensions, plus in the OPZ and in the 3D. Okay, our idea is to get the end threads within the fusion zone. Not too much, but not too less.
the bone implant contact or the surface area of the implant with the bone in contact should be higher. That is one requirement for a requisite for a still protector. Second, deeply seated corticals. It has to be well engaged, well locked into deeply seated corticals. Mind you, all the smooth surface implant should be locked. Only R-line has the immense property, very sharp, aggressive threads, which will clearly go and lock it into the corticals. So that you will have a very high torque. All the beginners and the regular users also can appreciate very high torque of R-line implants. Now the diameter of choice is 4.5 mm diameter. If the bone is good, if it is highly cortical with a thin this one width, then you can use a 3.5 mm. Now here I could see that after it is well surrounded by the bone, right? You have a good porosity.
Yes. Just maximize larger.
Stigmatization is also there. We don't have much of stigmatization. So here for an implant of size 23 mm, yes, the ounce fields are 430, 397, 36. Yes, preferably good one, good quality. Thank you, doctor. Thank you. So here, even with the tuberosity area, if you are going for this one, BCS 3.5 mm into 23 mm length, protocols, just make a note of it. First, C finder, tap, 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 go, get a nice sound, remove it, place it over there, take your drill, get your handpiece, straight handpiece, preferably our 1.8 mm conical drill, then place it into the osteotomy, don't drill. At a drilling speed of 5, keep the drilling speed at a 5000 RPM, and then just run it along the osteotomy freely, because already the osteotomy has been done by the C finder. Now just run it passively in the osteotomy. Make sure you are in the perfect osteotomy, and then with a single drill, just go puncture the corticals and then come back. After that, you can use a 2.0 twist drill. If the bone is soft, don't use 2.0 twist drill. The bone is hard, you can use a 2.0 twist drill. Again, refine the osteotomy. Mind you, the twist drill does not remove any bone. Twist drill will just compact the bone. After that, you can use 3.523. Any beginners in our group session, just make sure you are dealing with a 23 mm implant. You should not lose your orientation to the pterygoids. If you are in a doubt, again place your C finder. Just make it in your mind that what is the angulation, what is the how you are going, which direction you are going. Ask your assistant to remove the cortical finder. Make your finger as your guide. With 2 fingers bracing, slowly guide your implant into the position. You can see a very good high top at the end of 23 mm, and that's all done. So our zone C implant is done over here. Clear? Thank you, doctor. We'll go ahead with zone B, sir. Yeah, doctor, just a minute. If it was a compressive implant, yes. There are many queries that why can't we go for a compressive implant in an zone C? There are 2 reasons why we should not go and why we can go. When we have a good volume of bone, yes, of course, when volume of bone is very high, our king can come out there. KOS is king of single piece implant. Our compressive implant is our king. So whenever you have a good bone, yes, of course. Now here from the soft tissue, it is around 22 mm. So from intraosseous part of this particular implant is around 19 mm. So 19 mm, you will be having a 3 mm polished collar also. So you should take a size your compressive implant of size 18 mm or 15 mm. Clear? Say 3.7, but don't prefer 3.75. Use 4.2 in posterior maxilla if you need to go with a compressive implant. Often, when in a borderline case, don't try to place compressive implant because when the sinus gets pneumatized later on, sometimes the threads of the implants may be exposed into the sinus. But there are studies showing that threads exposed into the sinus with an intact Schneiderian membrane, sinus membrane, is not going to cause any problem. So, yes, of course, we can go ahead with a compressive implant. The drilling protocol is one and the same. Stop over here, use a twistle, then directly take 4.2 mm implant. When the compressive implant is half done and is not going more, you are giving more than 40 units and the implant is not being driven again, then you should use a 2.6 mm conical drill and then you have to drive the implant into the desired length. Okay, so this is done with the compressive implant. Yes. Now regarding zone B. Now zone B, nasally it is still the nasal extension of the sinus. Distally it is still the distal extension of the sinus, and occlusally it is your sinus floor. So the crest to the sinus floor area or the sinus area is called as zone B. So sir, we'll just start with we'll do the zone B later on. We'll find the strategic position. Our anterior strategic position is our canine. So we'll go ahead with the canine area. So next strategic position is our canine area.
See, this yellow slice represents where we are doing in this cross section. Okay. This is the canine area.
That's the coronal section.
Yeah.
Right side is the coronal section. You can see the
for the anterior, this is the coronal section.
Now the coronal section, you can appreciate a thick white line that is the sinus floor. No, sorry, the nasal floor.
Here it's a small artery here. Now canalier. This is the nasal floor, the palatal and buccal cortexes. Cortex 1, cortex 2.
Yes. Now our strategic position is the canine area, which is in the zone A. So we will place in first a BCS implant or a smooth surface implant initially, sir. So we will begin from the crest of the alveolar ridge. We will be going palatally. Our forefinger or the finger will be resting in the palatal bone. Our fingers are our CBCT. They are the guiding plates. So you should always have a finger bracing, thumb in the palatal vault and forefinger in the buccal circus area. If it is in the second quadrant, it is the opposite. If it is in the first quadrant, it is the same. Start drilling from the crest of the alveolar ridge. Palatally, you will engage a thick, nice particle plate at the end at 16.70. That is around 17 mm. You should pierce it.
So this blue line represents the soft tissue.
So positively, soft tissue will be 3.5 into 17 mm. Zone A, it is the nasal floor area. We don't want our implants to jet out of the nasal corticals. We want our smooth surface implant to engage into the nasal corticals. Never through and through. Don't put your implants through and through. Yes, it is a smooth surface. It will not create any infection. Everything is there. We don't want to create any such havocs and all those things. We should have our threads well engaged into the nasal cortical area. Perfect. Now the red color which you see in the 3D view, yes, that will show you how. See, it is our implants are just engaging into the nasal cortical, nasal fluid. It is just peeking out. Even the osteotomy should also be in the same manner. You should not run your conical drill beyond 20 mm. You will create induced nasal bleeding. Of course, that will be okay because just a 2 mm drill osteotomy only. But it is self-limiting also. But don't induce that knowingly. No iatrogenic effect. So this strategic.
We have a doubt, sir, on the chat.
Sir, pardon, sir?
One chat, one doubt is there by Dr.
Yes, how do we proceed when the bone is soft due to accessing cyst in the second model area? Yes, Dr. Sonal, I will surely get into it after this session. Just wait for the session to be over, sir, ma'am. We'll do it. Thank you.
Fine. Yeah, we'll keep the doubts at the end.
Yes, I will keep the doubts in the last, towards the last. But ma'am, we'll surely get back to you. So here, the preferable size or the width of the implant is 3.5 mm. Now, two school of thought is there. One is either use a 3.5 into 17 mm directly if you require more of bending is required for the abutment, because bendable abutments are only with 3.5 mm, right? If your angulation and if the bone is favorable, then what you can go is you can directly use a 4.5 into 17 mm and preferably don't bend that implant. Don't bend that implant. 4.5 dia implants are not bendable. Don't try to bend. So if the angulation of your implant is unfavorable, use 3.5. If the angulation of your implant is favorable, use 4.5. Because these are the strategic positions of the implants. You should have a solid anchorage in these areas. Without any doubt, because these are the boundaries of your polygon, you should have it. Without that, your full mouth is going to be in a problematic way. It is the basic structure or the we'll say the plinth of a particular building. Plinth of a building. Okay. Now, once it is done, yes.
Sorry.
Now we'll start placing implants posterior to the canine implant. So all the implants. Yes. Yes.
Yeah.
Yes.
Well, I'm just taking the cross section of that side.
Yes. Yes. Sir. Now we will have all the implants placed between canine and the pterygoid sections. Advantage is that these are all implants are all called as supporting implants. All these implants will help you to dissipate your forces falling. Where are the occlusal areas which we get? We get occlusal areas only in two premolars and mesial side of our molars. So all these forces has to be equally dissipated into the deeper corticals. That is the palatal cortical and the tuberopterygoid corticals. Okay. So for all these things, we require supporting implant. So one supporting implant will be keeping it in 1/4 area. Against the 1/4 section, this is the 1/4 section. You can see the coronal section. Again, it is the 3.5 by 17. From the soft tissue, directly we'll be placing 3.5 by 17. Just distal to the canine. So once you have placed your canine implant, just parallel to that, you can place your 1/4 implant. Now once we have identified our canine area, now we can know the 1/4 area. Now in an indigenous area, when we are doing a freehand surgery, how do we find just a trick? Ron sir has given me, I am happily sharing it to you also. All the participants over here, we have around 61 participants. The buccal frenum in the sulcus area, that represents your premolar segment. Okay, just anterior to the buccal frenum is our canine area, and to the corner of your nose, that is our canine pillar area. So that is I would say the tip of the day. It is easy to find out the buccal frenum and corner of the this one nose. That will help us to give it canine pillar area. Now 3.5 by 17 is done, 1/4 is done. Yes. Now we will have a 1/5. We see the cross section of 1/5 and determine how we can go ahead with 1/5. Here, yes. Now here comes our yes, a classical area. 1/5 From 1.5, our zone A is, we are having a border for zone A and zone B also starts. That is, we are under the sinus area. Okay, maxillary sinus area. So here in this 1.5 region, this sinus region, we have two choices. Either directly engage the sinus flow with a wide body. So sinus area with a wide body 5.5 by 40. It is a preferable area. Sinus area 5.5 by 40 is a preferable because it's already 12 mm. So I want to, normally whenever we engage our sinus particles, you should engage 1 millimeter beyond the sinus particle so that our ciliary membrane or the sinus membrane will act as a tent. The membrane will be just lifted. It will be like an indirect sinus lift. So we will be using a bit larger, 5.5. And since the width of the buccal width of the crest or the alveolar crest is just 4.5 mm, it is better we stick on with our 4.5 into 14 mm. 4.5 into 14 mm. So one protocol is directly with, mind you sir, 4.5 and 5.5 are wide body implants. They are non-bendable implants. So please don't try to put the, please don't try to put non-bendable implant. When you are trying to put a non-bendable implant, better you use a prosthetically favorable positions. That is, you put it directly straight. So 4.5 by 40. So that is our preferable area. So first we will place a 4.5 by 14 sir, and then we will give an alternate method also. Why 4.5 by 14? Also sir, because we are using a smooth surface implant, our implants should engage multi-corticals. When we use 4.5, we can have an engagement from buccal, we can engage the palpal corticals, and we can engage the sinus corticals also. So it should be multi-cortical engaged, multiple cortical engaged. That is why we are going ahead with 4.5. So 4.5 by 14, perfect. It should be prosthetically favorable with not much of bending. Start palatal, remain palatal. That's a key word. Start palatal, remain palatal. Finger bracing very important. Your thumb finger and your forefinger will be doing it. Right? So this is one method to engage into this particular zone B area. Now, we will also try to engage the palatal aspect of it. We will go a bit palatal to the sinus area and engage the nasal flow. This is called as sinus bypass. That is called as sinus bypass. Yes. So we'll remove that particular implant, sir, and then we'll start with our. We'll get that section, sir, coronal section. In the zone B area, often, sometimes if we are lucky enough or when the bone is favorable, what happens is we will have a palatal bone palatal to the sinus area. And the isthmus of that particular area or the width of that particular area is more than 4 millimeter. Yes, of course, you can go ahead with this particular protocol. If it is less than 4 millimeter, beginners are not allowed to do that because sometimes we may slip the implant into the sinus. So start more buccally and run more palatally keeping your finger braced in the palatal area so that you don't come out more palatally. Go slowly. The drilling speed at zone B area is 5,000 to 8,000, not more than that. Slowly. With an 1.8 mm conical drill, just perforate the nasal floor. Just perforate it. And mind you, the bending protocol is also different. The bending protocol in zone B when you are engaging nasal floor is different. It is well described in our textbook. Please go through that. In the surgical module, well described in the textbook. Please go through that. Only thing is, we should start more buccally and enter into the. You should bypass the sinus and then you need to enter into the engaging nasal cortical area. Now here we can see the length. So what will be the length, sir, to engage the nasal floor?
17 mm.
17 mm. Thank you, sir. So it is again 3.5 by 70. Perfect.
The width here is 4.4. So we have got 3.5.
Yes, sir. It's done. Perfect. Perfect. And sir, we have one more implant, sir. One more implant in zone B itself. Posterior to 1.5, sir. 1.6 region, can I have? Perfect. Ideal case. From the soft tissue, it is 10 mm to the sinus floor. So ideally 5.5 by 12. Yes, sir. The upper palatal width is 9.87. 5.5 by 10 mm will not be sufficient enough to pierce into the sinus cortical. Yes, sinus cortical is not at all reliable. I know that, sir. That is why we have strategic positions in the canine area. In the 4 is also we have engaged into the nasal floor. 1.5 also into the nasal floor, and then only we are engaging into the sinus radius. 5.5 by 12 mm. The flutes of the R-line series is designed in such a way that you take your 5.5 by 12, all the bones, they literally are getting compressed into the sinus floor area. Literally, they are corticalizing that particular area. You will get a very high torque at 5.5 by 12 when you are engaging into that particular area. So all the implants between the pterygoid implant and the canine implants are called as supporting implants. They help in dissipating the forces. They are all deeply seated into the corticals, well anchored into the corticals. That is what you should always know that. Now we need to have an implant anterior to the canine to resist the extruding forces. Right? We will have an intruding forces also, and we will have an extruding forces also. When we have chewing posteriorly, we will have an extruding forces on acting onto the processes. So we should have an implant anterior to the canine, that is in the 1-2 area. So in this 1-2 area, you can see a typical angular bone loss. Here you cannot expect our compressive implant to work on. Even if it is a BCS implant also, if it is not well designed, you will miss the osteotomy. Now in the 1-2 region, be sure anatomically you will have a depression in the cortical area, buccal cortical plate also. So you should start from the palatal aspect of the alveolar ridge and remain palatal. Here from the soft tissue we are having 17 mm in length. So we'll start palatally, sir, and remain palatally.
I'm just placing the one.
Yes, sir. Yes. This is a first kind of this type of presentation which Impact Airline series is coming up. Why? Because our main aim is to help our users, airline users, to plan meticulously so that you don't miss out any of the structures. You need to procure the implants and call us for the help. We will help you, we will guide you, we will help you in all forms, in surgical procedures, in prosthetic procedures, and in all the matters also. So you can always contact Trisa Enterprises for all the implant related queries. Again, I am reminding you for the boot camp which is coming up in Bhopal. So when you procure R-line implants, mentors are there to help you out with the cases. If required, they can provide you one-to-one mentorship also for all the queries for the upcoming boot camp. In boot camp, one full arch or on both the arches, you will be able to you will be able to place the implants. You will be able to assist another full mouth cases right from A to Z, right from surgical part, right from planning, right from prosthetic part till you finish, you complete your case also. For all the queries, please call Trisa Enterprises 9321 533 493.
So here we have put it palatal, sir. We
Yes, sir.
enter
Yes,
at
sir.
the
We'll start
palatal.
palatal and remain palatal, sir. Yes, perfect. Perfect, sir. That is how we should have. So that is called a stabilizing implant. Stabilizing implant. Here you should see that. So we are almost engaging the nasal spine. Nasal spine, a reliable cortical in the nasal floor area, but you should not be able to pierce that area. You should be just engaging that area. It's a very thick cortical area. Drilling protocol is the same. Drilling speed is 16,000 to 20,000. 1.8 mm conical drill, 2.0 twist drill, directly 3.5 mm implant. These areas requires bending for prosthetic fabrication. So please don't use higher diameter, wider diameter. If you want to use a wider diameter, then you should have an angulated abutment. That is also available. You can use an angulated abutment. Areas
Yes,
which
good
cannot
evening,
be.
Subodh sir. Subodh
Yes.
sir, sorry to interrupt you.
Yeah. Oh, yeah.
Dr. Rain here.
Hi, sir. Good evening.
Hi.
How are you
Yeah,
doing?
greetings. I am right now in Innsbruck,
Thank you.
and I just wanted to thank you. I was just catching some glimpses of our webinar before I take my next flight.
Yes,
So,
sir.
hello everyone. Good evening, greetings. It's around 5 o'clock over here. I think in India it must be 8:30, eight
Yes.
thirty-nine, something like that.
9:30.
Right. So, just wanted to just say hi to all our community members. And I just saw certain glimpses of certain things you are sharing. It's really amazing, because I myself, I know that such a kind of detailed what you're sharing is not available routinely in any of the books, forums, or anywhere else. So I
Sir,
wanted to just couldn't wait to congratulate you for such amazing insights what you're sharing.
thank you, sir. Thank you, sir.
And I hope all of you make good utilization of this webinar by Dr. Subodh sir. And it's just good to just connect with you all, I think, and the community members. So I requested Trisa Enterprise to just unmute me for some time, so I could just say hi to everyone. Yes, great, great, great. So nice to see all this routine name. Dr. Shravan Kumar, Benka Dental, thank you. Dr. Girish, Dr. Rahul, great. Dr. Rohit Menon, great, great. Thank you. Thank you so much. And sorry, sir, to interrupt your presentation, but I have to catch up. So I just request that team to unmute me in the middle of your presentation.
It means a lot, sir, to have you in your busy schedule also. Thank you. Thanks a lot, sir.
Thank you, thank you, thank you, sir. Please carry on.
Yeah.
And it's wonderful to hear from you as always, sir. Wish all
Yes,
of you all the very best, sir. Continue.
thank you.
Thank
Thank
you
you,
so much.
sir.
Thank you. અમારું ઓલું inner circle ચાલે છે એમાં થોડું guest appearance.
So we'll now push on to our second quadrant right now. So we have finished with the first quadrant. So we are having 6 implants, one on the maxillary sinus, one on the tuberopterygoid area, and in the canine area. These are the strategic positions. Now, distal to the canine area, we have 2 implants engaging the nasal cortical area, that is on the 1-4 and the 1-5 area. 1-5 area, we have did a sinus bypass area. And if on the beginners, if they can't do a sinus bypass area, that's fine. Use a 4.5 by 14 and engage the nasal maxillary sinus floor region also. That will be fine. Don't forget to put an stabilizing implant mesial to the canine, that is in the 1-2 area, because those are the implants which are very much mandatory to resist the extrusive forces of the processes. Now we again will start with our second quadrant, that is the left pterygoid region. Again, a small brush up with the anatomy. Yeah. Now again, our Hamla process. Just start with your forefinger, palatal to the premolar, run posteriorly towards your PPS area, posterior palatal seal area. You will find a very sharp bony prominence. That is your Hamla process. That is nothing but it's a medial pterygoid plate, extension of the medial pterygoid plate. Now you have an tuberosity ends at a notch that is called as Hamler notch. Now an imaginary line, we draw it from the Hamler process through the Hamler notch to the crest of the alveolar ridge. That will give us the medial angulation of our implant. That will give us our mesial angulation of our implant. Fine. Now, again, our C finder comes into play. Cortical finder, for anybody who is new to the cortical finder, just put a word in there. We will have a discussion on that in the end of the presentation. In the chat, you can just put an if somebody wants to have a discussion, we'll do it, sir. Maintaining the medial angulation posteriorly, superiorly, medially. Then just tap with a mallet slowly and then go into the tuberous area. That is, it is normally tuberosity area is D3, D4 quality. So you will have a muffled sound, but that muffled sound will get into a very sharp sound as and when you reach the fusion zone between the pterygoid plate and the tuberosity or the maxilla. Okay. So for all these things, once you start tapping, you get a very hard sound and then a very high resistance. Then stop that particular area. C finder is an amazing instrument. You just leave that C finder in that particular area. It will stay there. You will not lose your osteotomy path. The C finder will be there in the osteotomy path itself. Now, take your straight handpiece, put your 1.8 mm conical drill, directly 5,000 to 6,000 RPM only. Why? Because it's a zone free area. Now, take out the C finder. Now, remember, you just don't drill the area. Take your drill 1.8 mm. Without drilling, just scout that osteotomy which you have done with the C finder. It should be passive because C finder is 2.0 mm dia. 1.8 mm conical drill will be passive in the osteotomy. So just scout that area. Just go in and out 3 to 4 times so that you remember the osteotomy area. Then with the drilling, with your foot pedal under drill mode, with drilling, go and puncture the cortical area and then come back. When you puncture the cortical area, see BCS, smooth surface implant, we decide the size, length of the implant only during the osteotomy. So when you puncture the osteotomy, You just see the length, at what length you have punctured, that will be length of your implant. So that is the BCS implant. Now the width of the implant will be decided by the quality of the bone. That is the fourth dimension, density of the bone. If the density is very low, you should use a wider diameter. If the density is very thick, highly corticalized bone, you should use a 3.5 mm diameter. Okay. To drill for pterygoid is not to drill. Thank you, Rahul doctor. That is perfect. That is the key word, sir. To drill for pterygoid is not to drill. Yes, thank you. Now, after that, you just need to remove, again scout it with a C finder, then take your desired implant, then just drive it into that particular area. You will find amazing result with that. Now, again, we'll start planning. Nitin, doctor, please. It is done, doctor. 3.5 by.
So to make it more symmetrical,
Yes.
here this side, although we can place a 23 mm.
Yeah.
Here I've gone with the 26 mm. So
yes,
bilaterally we get same position on either side.
Okay, fine, sir.
Okay, it is in the 8 extraction socket. It's coming at
yes, fine.
Still so this is 26 mm, 3.5 by 26.
Okay, fine. This is done, sir. 3.5 by 26. Yes. Now, can you just show me around the implant? It is well covered by the bone. Yes, perfect. You have a good bone, and the density of the bone, yeah, not that much appreciable. So, how is the density, sir?
I'm sure.
Yes, it is just
not as good as the
as that of the
right side.
Yes, yeah. Right side, maybe you may go for the compressive implant. Here, I don't never suggest. We never suggest to go with a compressive implant, because when you put a compressive implant, you cannot corticalize this particular bone. You should use a very wide dia of the implant. 4.2 mm implant will not compress this particular implant. So it is better, perfectly done is our 4.5 mm BCS implant. So 4.5 by 26 mm. That will work nicely. Perfect, sir. Thank you. Sir, strategic position 2, 3, can we find, sir? Perfect. Perfect, sir.
Here we may go for 20 mm.
20 mm. Yes, sir. Yes, sir. Now, when this is more than 17 mm, anything above 17 mm, you should go jump into next size 3.5 by 20. Rahul, sir, will come into that matter, sir. We'll come into this matter after this discussion, sir. Second pterygoid, of course, perfect, sir. Done. Yes, sir. 3.5 by 20. Perfect. Also, sir, that's the perfect, sir. 3.5 by 20. So BCS smooth surface implant, you pierce the cortical, you should have one thread engaged into the cortical, not beyond that. That is the keyword. So our strategic position on the 2, 3 is done. Okay. So as said, if you want to put in compressive implant, you should use a 3.75 by 13 mm or 15 mm. Or if it is a BCS implant, yes, perfect, done. In that case, if you are in a bendable zone area which requires bending of the implant, you should use a 3.5 by 20. If you are prosthetically, if it is fine in a favorable area, you can use directly 4.5 by 20 also, because that will 4.5 implants will add rigidity to our system. When you have rigidity, then you can easily create monoblock. When you have a monoblock effect, easily the forces are distributed into the deeper corticals. So the flexibility or the isoelasticity of the system gets drastically reduced. Now we will plan with the supporting implant distal to the canine. That is in the tooth region. Yes, sir.
Yeah.
Once we have done with the canine area, when we are doing a freehand surgery, it is very simple. If you have gone through that OPG or in CBCT, then just follow parallel to the canine. Make it just parallel to the canine. We can see in the left side sagittal view, you can see that 2-4 region is just parallel to the canine, 3.5 by 20, well surrounded by the bone, increases bone implant contact area, helps to dissipate the forces perfectly into the nasal floor area. 3.5 by 20, perfect. Really appreciating the. This is done, 3.5 by 20. Now again 2-5 region. Now 2-5 becomes zone B, that is under the sinus region. Two five will become zone B under the sinus region. Sir, I would prefer to see the cross section first. Yes. So this is an area where we have multi-cortical area or fusion area, highly dependable corticals. See, the nasal floor fuses with the palatal bone, fuses with the floor of the maxillary sinus. Highly dependable cortical area. If we are able to engage that particular area, that is palatal to the sinus with a 3.5 mm by 17. Sir, positively is that 17 mm, sir? Just length and of that particular area, sir?
This
Yes,
length, right?
yes, sir. Yes, sir. Yes.
It's 18.
18, sir. Sir, can we? Yeah, yes, sir. Yes, sir. Yes, sir. So that is again 3.5 by 20. If we can engage that particular area, that is perfect. But to engage that particular area, you should start more buccally, follow the palatal vault, the slope of the palate with your finger, so that you don't go more palatally, and you will have a very good resistance in that particular area. And it's highly dependable. If possible, engage that particular area, sir. 1-5.
Actually, there's an extraction socket there. So
Yes,
I
sir.
think
Yes, sir.
17 will do.
Okay.
Even though
Okay.
length is there, but
Okay.
since we are going too buccally, I think
Yes.
17 mm to the socket.
17 mm will be fine, sir. Okay,
Fine,
good,
right.
sir. Good, good. Thank you. So this type of three-dimensional digital planning will give us an idea what are the sizes of the implants which we should have during this type of treatment. Where all will be having a good bone. How to harvest maximum cortical areas which can be utilized for our processes. These things can be done well digitalized, well planning. So when it is planned properly, our work is half done. We should mind our chairside time should be very minimal. So patient will be very happy after anesthesia when we start our case. If we could finish our osteotomy in another half an hour to 45 minutes, the whole of the surgical procedures, patient will be very much happy for us. Even we will be having, it will be incorporating more confidence for us. Yes, I am having all of the armamentarium. I know what is the bone, how is the bone, how it is going to be, where all I have to engage the sinus, where all I have to engage the nasal floor. All these things is well known in advance. Now I need not run. If I don't have good armamentarium, if I don't have good sizes, then I will be start compromising on the sizes, on the width of the implant. Later on, I will be paying for all those things. I will be burning my hands. So don't do that. Okay. Thank you, sir. And regarding, sir, can we have one more implant distal to that in the 1-6 region, sir? Just a typical zone B, sir. Typical, yes, sir. Perfect.
2-6,
Typical zone B.
2-6.
Yes, sir. Yes. Typical zone. So 5.5 by 12 will be fine, sir?
Yeah.
Yes, sir. So the buccopalatal width is more than 8 mm, 5.5 by 12. So R-line users will appreciate the flute dimensions and the flute characteristics with an anti-rotation properties. It is sharp, aggressive at the threads, exponentially growing into the larger flutes. So whenever the 5.5 and 4.5 mm is being engaged, it takes away some of the bone also along with it, corticalizing the apical part more, giving a very high insertion torque. It will retain the corticalized bone on that particular area so that it remains corticalized throughout that. Often in many other designs, what we can see is 4.5 and 5.5 are uniform designs. They are called as fan-shaped implants in some other designs also. What happens is they just move and engage buccopalatal and multicortical sinus fault. They don't have compressive properties. R-line is having a compressive properties also, which will add on to our armament area. It will add on to our prognosis of our case. So these are the supporting implants which we place between the strategic positions of 2, 3 and the pterygoid implants. Now we should plan one stabilizing implant to resist the extrusive force of the prosthesis. So that stabilizing implant is always mesial to the canine, mesial to the canine implant. Okay. 3.5 by 17.
17 will.
Yes, sir. 3.5 by 17. 3.5. Thank you, sir. So here, positively, either we'll be engaging a nasal spine area or the nasal floor also will be fine. Nasal floor also will be fine. Often in some CBCT reports, we'll find a very wide canal, incisive canal also obscuring our area. Here we have, sir, do we have an incisive canal over here, sir?
Sir, well,
Not
it's
very
small.
wide, not very wide,
Not
small.
very wide.
Okay, thank you, sir.
Here I'm going palatally.
Palatally, sir,
As
palatally.
Steve tutored me, and engaging it
Yes, sir. Yes.
slightly onto the spine area.
Yes, sir. Reliable cortex, nasal spine. It's a highly reliable one, will never resolve. Perfect, sir. Sir, can I have an occlusal view on the left lower section, sir, so that I can show the symmetrical aspect of the implant procedure? Yes, sir. Surgical implant. See that. Say our roots, artificial roots, or what we call it as our implants, all are well arranged in a symmetrical pattern. He is now ready to absorb the occlusal load which is coming up in the two premolars and the molar area. So it is well deeply seated, well cortical in the well cortical bones with the maximum bone implant contact area, no exposed threads, everything is perfect. Now we have to create a monoblock, or we have to splint all the implants. We should put it in all one frame. We have two options. Either make an impression, you send it to the lab, make a jig, get it corrected, then do a metal frame. So that is one conventional method. Those who are much advanced, we have scan bodies. Do a scan body, just scan it, send it to the lab. We will have the metal frame readily done. Just adapt it and cement it. Perfectly done, sir. The third one is the Mr. Dependable intraoral welding. So intraoral welding, I'll just cover one glimpse of it. Two wires, 1.6 mm from pterygoid to pterygoid, perfectly well adapted. One gingivally, that is with a close adaptation with the oral the mucosa, and the other one above, just above it, will work perfectly good. for intraoral welders and for intraoral welding wires, contact Trisa Enterprises. They'll help you out. Whenever you are opposing a natural dentition, when a maxilla, edentulous maxilla is opposing a natural dentition, 1.6 mm 2 wires is very much mandatory with a rigid processes of HIPC or a GCAP or a PFR or a zirconia. Please avoid using of an acrylic processes opposing a natural dentition. So positively, we have finished our planning of our this one maxilla. Hope everyone is, yes, number is there in the chat box 9321 533 493. Thank you, ma'am. Now, if participants are okay with the maxilla planning, can I have a thumbs up or an yes? If I am not bothering you, if my lecture is not boring up, then can I have an yes? Can we move ahead with mandibular planning? Thank you, Neelkant sir. Thank you, Mansoor sir. Thank you, Benaka. Thank you, Dr. Rahul. Thank you, Dr. Akash. Thank you, sir. Yes. I tell you, ma'am, can I have an 45 minutes extra? Yeah, I will not.
Sure, sir.
Yeah. Thank you, ma'am. Thank you, ma'am. Yes. Yeah. Now we have our zone D, that is the pre-mental foramen region between the areas between the two mental foramen, and we have a zone E area, which is the posterior mandible. Okay. Now, relatively, posterior mandible will take up zone E, left mandible, left side of the mandible, that is the third quadrant. Just we'll run through the coronal sections. The nerve has already been traced up. But see, sir, there is a defect, no, sir? Yeah. Fine. Okay. So we can appreciate the mylohyoid ridge, right? And then when we are running posteriorly, we have two options in the posterior mandible. Either you should go with a lingual cortical engagement, that is inferior to the mylohyoid ridge, or a buccal cortical engagement, that is inferior to the external oblique ridge. Okay. So here in the coronal cross section, you can see that either it is perfect, sir. Thank you. That is the external oblique ridge. The cursor which moves is the external oblique ridge. Sir, external oblique ridge. Can you just point out the external oblique ridge? Yes, perfectly, sir. Perfect. That's the external oblique ridge. And now we have the mylohyoid ridge, or we call it as an internal oblique ridge. Perfect. So our implants will be safely seated when it is in the deepest concave part inferior to the mylohyoid ridge. That is the thick cortical parts. We will be engaging into the concavity of the mylohyoid ridge. That will be safe over there. Our floor of the mouth is well attached with the mylohyoid ridge, so the tongue will not be able to percuss into that particular area. Don't get worried. The tongue can feel only if the implant is placed very superiorly. So we will not be doing that. And buccal cortical engagement only if it is that favorable, we will be doing it. Otherwise, we will always go ahead with the lingual cortical engagement. So coming up with the lingual cortical engagement, yes, perfect. So with the lingual cortical engagement, what we can do is, we should always start with it is always in an oblique direction. So think that we start from mesiobuccal area and we end up, or we come out from the distal lingual area. Drilling protocols, always you should keep your forefinger under the mylohyoid ridge and feel for the drill peeping out. The sharp conical drill should literally pierce your finger. Don't try to pierce your finger. The tip of the drill should come out. Initially the heat, you will feel the heat, and then the tip of the drill also will come out. So that is what it is. The aim is to start from mesiobuccal, end up in the distal lingual area, the deepest part of the mylohyoid ridge. Clear? Now what happens is the speed of the drill should be 16,000 to 18,000 RPM, 35 Newton speed, preferably a straight handpiece of 1:1. Some operators even prefer 1:1 contra-angle handpiece also. 20:1 handpieces, we don't prefer because 20:1 handpiece, with 20:1 handpiece, it is very difficult to pierce the particles. Again, two implants in the zone E in the left mandible. Yes, sir. We started from mesiobuccal area, coming out from the distal lingual area. From the soft tissue, it is measuring 3.5 into 14, sir. What is the length? Yes, sir. 3.5 into 14. Perfect. So the length is 3.5 into 14?
14.
Yes, sir. Perfect. Okay, fine, sir.
Now, one parallel to that.
One parallel. Yes, sir. One parallel to one more implant parallel to this implant. Either distally or mesially, where the mylohyoid ridge is more prominent. Two mistakes which often we do is we don't start mesiobuccal and target distal lingual, but we start straight. So what happens is we will be ending up with a 3.5 mm, 12 mm or a 10 mm length. What happens? Okay. 3.5 mm into 12. So the bone implant contact is reduced. One, if it is straight, then you need not bend that much. Okay, the bending will be very difficult. Now 3.5 into 10 mm implants are very difficult to bend. So 12 mm is fine if it is well corticalized or well fixed into the corticals. So the length of the implant can be increased if you are going from an oblique direction. So it is always better you start from mesiobuccal and end up in distal lingual area. You can see the 3D, three-dimensional view of that. Yes, sir. Perfect. Yes, sir. Now, can you show the lingual aspect, sir? Yes, perfect. Now, here, sir. Sir, the distal aspect, can we reduce it into 3.5 by 12, sir? Distal most implant. Perfect. This is the ideal thing. Your implant should just engage the corticals and peep out. It should not come out of the bone. No perforations inside. Okay. Even in the nasal floor and even in the posterior, because all these posterior mandible and in the nasal floor, there are very thick corticals. You can find the corticals over there. It is very thick and you will feel it very high resistance. R-line will give you very high torque inside. So these implants will be very much locked inside the implant that you can very well bend into your desired prosthetic happen. Perfect, sir. Perfect. 1352 ounce 1240. Very good, sir. D1 quality. Thank you. So these two. And here the external or the external oblique ridge is not that prominent that we can engage into the buccal corticals. Buccal cortical engagement will be very difficult. Clear, sir? Now we will do the right side of the mandible. Fourth quadrant. Right side, fourth quadrant. Yes. So two implants starting from mesiobuccal to the distal lingual in an oblique direction. This is what happens. When you ask a CBCT guide to give you a section of the mandible, this is what happens. We will have a horizontal section. In basal implantology, we don't want a cut section. We never want cut sections. We want sections according to our wish. We wanted sections into. Is the surgical process same for KOS implants? Dr. Sonali, ma'am? Yes, I am coming for that. Yes, ma'am. I'll explain. No, ma'am. Whenever we are going for an... Yes, ma'am. I'll just complete this, ma'am. So in the... Sir, we are coming... Yes, sir. Perfect. So in the basal implants here, we require it. The legs, the implant should be like a legs of the table. It should be flared out. That is why we are starting from mesiobuccal and ending up in distal lingual. We will have a longer implant. We will have more bone implant contact. We will have more area for force distribution. So these things will be preferable if you have an oblique. If you do the osteotomy in a oblique direction. Now, ma'am, Sonali, ma'am, when we are doing a KOS implant, we directly put it on the from the crest of the alveolar ridge or prosthetically favorable. We don't bend KOS implant. We cannot do a KOS. We cannot bend an KOS implant. If we still want to have a head bent, we should use an angulated abutment. Now, KOS implant should be used only in a favorable position. Here, I don't think that it is that favorable. Yes, of course. I'll just plan this with a compressive implant also later on. In the fourth quadrant, I'll just plan with the compressive implant. Yes, sir. Now, two implants we have already planned up. Now, from the methiobuccal direction to the distolingual direction, engaging the lingual cortical, underlying the mylohyoid ridge, not on the mylohyoid ridge, not superior to the mylohyoid ridge. Place your finger under the concavity, in the concavity of the mylohyoid ridge. Get your finger pierced or get the heat of the drill coming out. Let the drill come out with a 2.2 mm twist drill. Let the drill come out. At the time of the drill coming out, you can measure the length. It will be around 3.5 by 14. Sir, this is fine. The length is 3.5 by 12 and 3.5 by 14, no, sir?
Correct.
Yes, sir. Distal implant is 3.5 by 12.
By 12
and
anterior is 14.
And it is 3.5 by 40. Yes, sir. Perfect. Done. Right. And then we engage our one particular thread in the corticals. Our implants should engage the lingual cortical. It should just peep out. It should not come out. Perfect, sir. Perfect. Sir, I want to help, sir. Fourth quadrant, can we plan for an compressive implant, sir?
Shall we do it in 4-5?
No, sir. 4-5 we don't.
Yes.
We'll do it here, sir. Yes, sir. You can delete that implant in the fourth quadrant.
Okay.
We'll plan for a compressive implant also. Just check it out. I'll check for the quality of the bone over there, and then yes, sir. One will be fine. Perfect. Yes, sir. So in mandible, we use normally we use 3.75 implant. If it is very thin, we can use 3.3 implant also. Now the effective endosseous length of that particular site is 12 mm from the vital structure, that is your inferior alveolar nerve. Okay. Now we should be aware that our compressive implant is having 3 mm polished surface. Now 3 mm polished surface is given for our compressive implant is to give a thick mucosal barrier, smooth mucosal barrier to prevent peri-implantitis. In many designs, they have many different types of smooth surfaces, and our thick, highly polished anodized collar gives a very thick mucosal barrier which will prevent the peri-implantitis occurring. Now, from the crest, we have just 12 mm. Now, 2 mm of the polished area, we will use it in the gingival area. 1 mm subcrustally also we will be losing. So, we will be having only just 11 mm. So, it is always better we place 3.75 by 10 mm implant. So, just sir, please, can you please place 3.75 by 10 mm, sir? 10 mm. Length is 10 mm.
Okay, sir. I'm just putting it.
So length is 10 mm, sir. It was 11 mm, sir. Because we will be placing 1 mm subcrustally, 1 to 1.5 mm subcrustally. Yes, sir. Perfect.
I've corrected it now.
Yes, sir. Perfect, sir. Perfect. See, ma'am. Sonali, ma'am, now for a compressive implant, see, it is perfectly placed, but the operator who is using compressive implant should be well aware of all the properties of compressive implant. Now, can you just imagine here, you don't have bone lingual to the implant. All the bone, buccal and lingual to the implant are highly corticalized, that you don't have bone for compression. Then where do you get to have bone for compression? Now the bone has to expand. Now here we will be using more forces for the implant to be in position. We should do a subtractive method. We should remove more bone. In a highly corticalized mandible, In order to put a 3.75 implant, we should remove more bone. The every chance is that we may end up in compression necrosis. So it again, for an R-line KOS implant, you will never have compressive necrosis because the threads and the conical form of the implant is designed in such a way that the compression is equally dissipated throughout the implant. But still then, if you want to use a compressive implant, you should do a proper osteotomy. Osteotomy will be 1.8 mm conical drill, then 2.0 twist drill. Here, since it is a D1, D2 bone, you should use also 2.6 mm conical drill, remove some of the bone, and then start placing the implant. If the implant is gone half the way and is above 45 Newton, it is not going inside, then again you have to remove some more bone and then again place the implant. Only the last 1/4 of the implant has to go. Then just widen the osteotomy with the bone screws available in the R-line kit. It's a superb instrument. 3 mm bone screw available. Bone tapping screws are available. Just use that to the working length of 12 mm and then place the implant. Compressive implant is like a king. He should just come sit in his throne. You should nicely prepare the bed for him. He should have just come into the position. Just nicely sit in his throne. Only that much, man. But all the bending, all the errors and all those things are available only with a smooth surface. So it is always better we play with smooth surface, BCS. Okay. Thank you, sir. Sir, we'll go with zone D, sir, between the mental filaments. Perfect. Yes. So here we'll put it straight, sir. So the beauty of the zone D is you need not pierce any of the corticals. You need not pierce any of the corticals because zone D is gifted with layers of cortical bones. You will have many multiple layers of cortical bone. You should just engage your basal bone. So just take your 1.8 mm drill, remove the extracted tooth, go 5 mm down apical to the root. Get it. If you are getting a resistance, happy, get it out. Take a 2.0 twist drill. Just check it out whether you have gone buccally or lingually. You should be always remaining between the cortical plate and the lingual cortical plate. You should never perforate the lingual cortical plate. A strict no for lingual cortical perforation. If you really want, what you can do is you can start from lingual, from the alveolar crest and angulate your drill towards buccally. Here, to increase the tripod effect of the lower mandibular prosthetic segment, you can give a mesial tilt to your processes also, as sir has given. So 3.5 by 20, sir, or 17 mm, sir?
17.
17. Thank you, sir. So from the 4 region, just with the mesial tilt, engaging the inferior part of the canine bone area, canine apical area, it is 3.5 by 17 and bend the processes. Jyoti ma'am, thanks for reminding it's 10 p.m. I'll just fasten my presentation. Thank you. Thanks a lot, ma'am. I'll just take another 15 more minutes, ma'am. Sorry.
Yeah, we'll do it fast.
Yeah, we'll do it, sir. We'll have one more implant parallel to 4-3 region. Perfect. 3.5 by 17. Done. Yes, perfectly done. Right. So now you have another in the 4th quarter.
One more implant, sir?
So no, sir. In the 4th quarter, not required.
Same replica in the
same replica, sir.
quarter.
Yes, sir. Yes, sir.
Here we have a defect.
Yes, sir. We have a defect order. So you need not have an 17 mm, sir. You can have a 14 mm also fine, sir. Just replicate it. So here in order to create, we have two legs in the zone E area, which is widespread into the lingual cortical area. If the buccal bone cortical is fine or is favorable, we can have a buccal cortical engagement also. In the zone D, we will be placing two implants. All the two implants will be mesially directed. Angulation is from the buccal, from the palatal or the lingual aspect to the buccal. You should never pierce the lingual corticals because we have lingual plexus of veins. So that is a strict no, because that is the biggest accident which can happen. Bleeding of lingual arteries, lingual veins, lingual plexus of veins. The management is very difficult. And in the buccal corticals also, you are not supposed to pierce because we are having muscle attachments throughout the mental in the inferior border of the mandible and the premental area. And after this, all the abutment heads are bent. If the compressives are there, or if you are using a 4.5 millimeter diameter, any implants are there. In order, if you are not able to bend, we can have an angulated abutment. Angulated abutments are available with the Trisa Enterprises. After that, the impression making is the same. For the conventional implants, we keep the impression caps. We make the impression with a putty, no light body. Then jig and followed by metal trial. In the second one, we can use the scan body, scan it up, and directly we can have a metal trial done. Third one, immediate splitting is done by Mr. Dependable or intraoral welder.
Here, do we reduce the bone here?
Sir, if you are going for a flap and all, we'll go do it, sir. Otherwise, we'll just plan it up right now.
Okay.
Yes. Now, sir, can I have an occlusal view, sir? Yes. Perfect. Thank you. So all eight implants are there. Never under occupy maxilla. Maxilla should be 12 implants, 10 to 12 implants. Mandible should be 8 to 10 implants. We can add one implant more in the premolar region, 4-5 region, 3-5 region. So wide diameter 3.5, 4.5 by 10 or 12, depending upon the length of the socket. And underlying inferior alveolar nerve canal, we can give a 4.5 mm diameter implant also. Now, after welding, either we can directly scan the implant, this one, and go for the processes, or make an impression with alginate. Nowadays, we do only scanning, and the processes as it is the same as that of the maxilla only. If you are having an opposing natural teeth, you should have a rigid processes, preferably an GCAM or an HIPC, or an PFM or a zirconium. Now, if you are having both arches, if you are having processes, then we can go ahead with an CAD-CAM acrylic with ivoclar tape and ivoclar material. Perfectly done. Or a metal frame with a composites also can be, or we can also think about that also. Now, so these completes our digital planning of our both maxilla and mandible with our implants. Now there are two things which we can do. Once we have done the planning, what we can do is either if it is well healed, we don't have much of implants, and if you are well trained, you can very well go ahead with a freehand surgery with all these things. This can be you can plan all these things. Even many softwares are available, like what we have is a Blue Sky. So these are all well available. We can do it. Or what you can do is you can prepare for a surgical guide. Now, advantage of a surgical guide is you will be more precise how you have planned. You can very well come into action. Once you have done with the action, then you need not worry about it. Yes, perfectly you are there in the implant. Perfectly you have done the implants. What length you got a cortical, the same length you will get with the surgical guide itself. So the only prerequisites with the surgical guide is the workflow will be a bit different. So we'll have a quick gesture, another 5 minutes, how to go about with the surgical guide, and then I'll come back. I'll just show you one OPG also. how we have planned it three-dimensionally and how it has done. It was from one of our course only. We will do it afterwards. Nitin Doctor will do it after that. Now you can just brief the workflow of how we have to go ahead if you are going with the guide. So
Okay.
over to you.
Can you see my screen?
Yes, sir. Perfect.
Yeah, 1 minute. Yeah. So I'll just talk about a normal workflow. What before we go to a fully edentulous, what we require. Okay. So initially, of course, we need the CBCT data. I'm talking. This is in case where we are doing edentulous patients, as in or partially edentulous patients. We usually require the intraoral scan and the CBCT, or if a CAST scan is available, we'll do that. So from there, we do a crown down planning. Usually, we do a crown down planning in case of it's dentulous patient, and think about the processes first, where it's going to come, and then plan the implants accordingly based on the strategic positions, based on the tripod affecting, based on the cortexes available. Okay. Now, if it is an edentulous patient, there's no, so to do a flapless surgical guide, you need to stitch two scans, the soft tissue scan and the hard tissue scan. But for if edentulous arch, it's only the gingiva, and in the CBCT, you will not get the gingival margins. You will only get the bone. So there's no common point between these two scans. So what we do is, if the patient is already wearing a denture, or if he's already a um, existing denture wearer, or or if he's not a existing denture, we make a special tray or we make a temporary denture, and we place some markers. Okay. Now these markers can be commercially available metallic radiographic balls, or more commonly we use GP or any other radiographic material. What we do is in the denture, uh, uh, we'll be making ditch cuts at certain different positions. You can see all these positions are not overlapping each other. Okay, so around 4 in the buccal and 4 in the lingual or palatal area. Okay, and those points which are not overlapping. The idea is, uh, first we'll make the patient wear this denture which has radiographic markers, both upper and lower if it is available. Ask the CBCT center to get the scan done with the patient wearing the denture and in his occlusion. Okay, with the denture in occlusion. You can even make a bite registration. If you are changing the bite, if you are increasing the VD or something, you can even make a bite registration and then give it. So the patient will wear the denture and take the scan. And once that scan is done, scan 2 is just the denture, whether it's upper, lower, both together. Just the denture, it's a separate. Either you can separately scan upper denture and lower denture, or together. In some CBCT machines have a platform to stabilize both upper and lower together in one shot. So ideally, theoretically, you need only 2 scans. One, patient scan with the denture with radiographic markers, and second is of only the denture with that radiographic markers. Once you have that, what we get, I'll just show you what we get in the case we did before. I'm just sharing my screen based on that. Hello.
In sharing lost.
Can you see now, sir?
Yes, sir. Yes, sir.
Yeah. So this is that CBCT, and this is those radiographic markers. So it's a case done at Dr. Subodh's clinic. You can see that there is both upper and lower markers. You can see. To see it more clearly, you can. I'll show you in this view. Can you see this white dots? So you can see that the patient was scanned with the occlusion, not with. They don't keep a bite fork in this case. Okay. So you'll have to specially mention that when you're sending for the scan, that please do not use, if the patient has biting down on the upper lower denture. Okay, and once we have that, we also get the denture scan done, right? So even the denture scan will have those points, radiographic markers where we have placed it, and that the software converts that scan into a 3D object, merges with this uh, uh, with the our model, and then we get a proper soft tissue data. So that's how in this earlier case, if you remember, we have a cast. So how we got that cast is we inverted that denture and we got the soft tissue outline of that. So to analyze the soft tissue to hard tissue distance and also to get a proper length while planning basal implants, this data is required. If the patient is dentulous, we don't have to worry about all this. Just have to get the intraoral scan stitch it with that. The patient is edentulous, we follow this protocol known as dual scan protocol. Okay, so kindly when you are sending for CBCT, please mention it well clearly that it has to be done in a dual scan method. Some of the centers may not be aware of what it is. In that case, we'll have to explain. So again, I'll just explain it. So the first is basically you need to have a denture with radiographic markers like this. And once you have that, ask the patient to wear it while taking the scan. And the second scan is only the denture. You can see this denture is stabilized on a plate and then scanned. Okay.
Thank you, sir. Thanks a lot.
Yeah.
Sir,
I hope that even in the OPG, you can see
yes,
this.
sir.
So,
Perfect.
That's how we get this. That's how we are able to plan a guide on this and all the other things.
Right. Fine, sir. So for a surgical guide to be prepared, the basic requirements is if you have teeth, then that's fine, perfect. Teeth will give us this soft tissue data also. But if you don't have a teeth, then what we need to do is we need to have a denture or a denture base with a radiographic marking and take that patient to the CBCT area and get them CBCT done not with a bite fork. You should not use a bite fork. You should ask them to use it in occlusion. You should always ask them to take a CBCT in occlusion. And later on, the CD or the denture base with the radiographic markers are also taken. CBCT is taken for that part. Both the scans we have to send it to this particular the person who is making a guide for you. This is how we prepare a surgical guide. Now, sir, do we have any photos for a surgical guide? Yes, sir. Yes, sir. Yes, sir. This is what I wanted. Yes, sir. Please.
One minute. I'm just doing it all. Yeah. So this is how a guide will look. It will be. I'll just show you arbitrarily how it will. Just quickly show it what is this.
Yes. Now the surgical guide will have a sleeve of 2.2 millimeter, but both. So it will just have. It will be just the hole will be very smooth. So just to have our R-line 1.8 mm conical drill and 2.0 twist drill. Just go inside so that you don't deviate the path. The osteotomy is perfectly done and we are engaging into the nasal cortical areas. So, and you don't go beyond your corticals also. Advantage of surgical guides, perfectly. One is perfectly met. You don't miss the corticals. The sizes will be perfect. So the we will be confident enough that we have all the sizes for our cases. Second, effort what we put. See, our effort we need to reserve for next cases also. You can't, we are all practitioners, we all do daily dental practitioners, we have cases, other cases also. So we should be able to finish our cases with 1 to 1.5 hours and later on do our rest of the dentistry work also, not only implants. So what we need to do is we'll have maximum of when everything is ready, just place this surgical guide into the patient's mouth. If it is fitting properly, then take the drills, do the osteotomy, remove the surgical guide. Now we know where the osteotomy is done. Perfectly start placing the implants.
Yeah.
The
So this
only
is how the
difference between
guide.
this type of surgical guide and the guides which we use in conventional implant is, in conventional implant we place the implants also through the guide. Now in this type of guides we do only for osteotomy. So this is the differences. But for an expert doctors, when everything is planned, they can do a freehand surgery also. That is also done. So here the money is we have less effort. Our investment is less. Money is saved. Time is saved. Effort is saved. Everything is saved. And digital dentistry, our corticobasal implantology becomes more easier, more viable to many of our patients also. Nitin sir, thanks a lot, sir.
Yeah.
Sir,
To see
actually,
how this guide can be used by an expert, please attend Dr. Subodh's course. He'll show you within 5 minutes how he finishes all these osteotomies.
thank you, sir. Thanks a lot, sir. So Nitin sir, actually I wanted, can we have a OPG shared, sir? After planning, any OPG, do you have any OPG? Post-op OPG?
The one you shared today.
Yes, sir, please.
1 minute. I'll just share.
Yes. And we need to show one buccal cortical engagement also, sir. Just one buccal cortical engagement. Ah. Oh, thank you, sir. Yeah, this here the strategic positions. Yes, sir. Hope my cursor is also visible for you, no, sir.
I think there is a pen.
Yeah, no, that's okay. Now the strategic positions 4.5 mm in the pterygoid areas. Now the canine areas are 4.5 mm. Perfect. And then we have two supporting implants, 1.4 and 1.5 region engaging the palatal cortex. One wide body implant 5.5, 4.5. No, that's a 5.5. Yes, sir. 5.5 by 12 and 5.5 by 10 in the second quadrant. One stabilizing implant in the lateral area. Now lower, two lingual cortical engagement on zone E and the zone B, of course, between the between buccal and lingual corticals, not piercing the inferior border. I hope this was done before we take before we were doing an welding actually. Here you can see two wire welding, 1.6 mm two wires, right? Um, so thank you. Thank you, Nitin Doctor. Thanks a lot, sir.
Okay. Thank
All right,
you.
sir. Just if you can enter. So today, I hope I was taxing too much. It's already 10:30. Thank you, sir. Thanks a lot. I would hope my presentation was better and it was clear actually to some extent that how the digital planning in corticobasal implantology will help us. Only thing we need to do is we have Dr. Rohan sir is there, ma'am Mayuri ma'am is there, myself is there, and many seniors are also there who are also practicing R-line implants. So once you have procure implants and all those things, and if you really want to help, us to help you, just contact us. If you want a one-to-one help also, we'll be there to help you out. So both OPG and CBCT will help us in a lot of ways. Preferably in OPG, we'll see what is zone A, what is zone B, zone C, zone D, and zone E. How the sections are then, how obliquely. Just putting a CBCT sections in our group and to give an OPG planning or give a treatment planning or sizes we'll never do. We need to know at what level, what plane angle we'll be doing it. All these things, all the things which we need to learn. So zone A, what will be the angulation? Zone B, what will be the angulation? Zone C, what will be the angulation? Zone D, preferably it is 20:1 handpiece. Quadrangle will be fine because you need not pierce any corticals. 1:1 also will be fine. Zone E, it is 1:1 straight surgical handpiece or quadrangle handpiece depending upon the operator. Now zone D, I forgot to mention this one. Speed will be around 14,000 to 16,000 RPM. Zone D and E are one and the same because mandible requires a higher amount of RPM. And 1:1 handpiece will be the fines. So thanks a lot, sir. I hope I have done my work. Um, and all the I know inner circle members are really working hard. They are actively participating in our all discussions, and they are the core participants who really enjoy particle basal implants. So whatever things I have done, I have done to share what I know. All the knowledge what I have done is clear to you, and if at all, if there are any hiccups or hurdles or any misguidance from my part, I feel sorry for that. Thanks a lot, sir. Thanks a lot. Again, I thank Dr. Nitin, who is my buddy, who helps me with all these planning and all those things. He is always there for me to help out, and we work as a team. And then, of course, my parent group, Trisa Enterprises, sir, whom I am associated with, and the academic part also, and my mentor, Dr. Rohan Virani, sir. So please, all these things are there in our textbook, surgical part and the prosthetic part also. So, and I could hear why there was no acrylic processes should not oppose in natural dentition. The simple, there was a very big um, subdivision is also there in our textbook, prosthetic textbook. But in a simple words, I will say acrylic processes, what absorbs is it absorbs forces. It is one way good for our implants. But what happens is when it absorbs forces, there is always a tensional or a torsional forces acting on the acrylic processes. Sometimes teeth may chip off or there may be a midline fracture also. So all these things are unwanted for our patients because whenever we deliver something to our patient, they should always keep smiling, and we work hard to keep them smiling. So that's all. It's like it is like a give and take only. So thanks a lot, sir. And Chaitali ma'am, hope I have done my best.
Yes, sir. Thank you so much for the session. And if Mayuri ma'am also wants to add,
Yeah. My
yes.
actually I couldn't see ma'am. Oh yeah, yes ma'am. Thank you, ma'am. How are you, ma'am? Ma'am, your voice is mute.
Yeah, just 1 minute, sir.
Thank you so much, sir, for excellent presentation. It was very insightful and clinically valuable throughout. Sir, I don't think anyone explains digital dentistry as clear.
Ma'am, not audible. Ma'am, not audible. Not clear. It is mute.
Am I audible now?
Yeah. Yes, ma'am. Yes.
Sir, I was telling, I don't think anyone explained digital dentistry as clear as effective you have done the job. It was wonderful, sir.
Thank you, ma'am. Thanks a lot, ma'am. Now, actually, we have done only a glimpse of it, ma'am, because we will be we can go ahead with the prosthetically driven industry also. Now we are already working on it, no, ma'am.
It's
But
quite fast, sir. If we come.
yes, ma'am. Yes, ma'am. Ma'am, this itself took me around 2 hours, ma'am. Sorry, ma'am.
No, sir, but it was good, not boring at all. So everybody, I think, enjoyed this presentation.
Thank you, sir. I could see many thanks, Dr. Sandeep, Dr. Shravan, Dr. Sumitra. Thank you, ma'am.